secretion of a hormone or under secretion. So two opposites. So we had hyperthyroidism, we have hypothyroidism. Same thing with parathyroid disorders. We had hyper and hypo. Pituitary, the same. We have hyperpituitary, hypopituitarism. Now let's go down to the adrenal glands. Teams, nurses, are you able to see my screen?
Yes.
Yes, I can see it.
Very good, children. Is it big enough or too small?
Perfect.
All right.
Perfect.
Perfect. Like my eyebrows. All right, let's review. So the adrenal glands have two parts. We have the adrenal cortex, then we have the adrenal medulla. The cortex part produces three hormones. We have the salt, sugar, and sex hormones. As far as sex hormones go, this only applies in the female because the sex hormones in the male are in the testicles. So again, the adrenal cortex produces salt, sugar, and sex hormones. Salt, sugar, I'm referring to the mineralocorticoids or aldosterone right here. And then you have your sugar hormone, which is cortisol. That's your glucocorticoid. And the sex hormones or your androgens, or specifically estrogen. So all is of stress, whatever stress, physical, emotional, whatever. It's a emergency hormone in order to maintain blood sugar during emergencies, so or during periods of fasting, for instance, in between meals. That's how we survive. It breaks down our sugar stores from the liver, maintains blood sugar levels. We have aldosterone, another emergency hormone, released usually with changes in your fluid volume. So the triggers usually is low blood pressure, low oxygen, low sodium, and low blood pressure. Did I say that already?
Yeah.
Yeah. Yeah, or high serum osmolarity, meaning indicating dehydration. So it's part of the renin-angiotensin system. Okay. And then finally, sex hormones. Sex hormones we won't worry about as far as it being life-threatening, although it's significant in the female because this will cause body changes, specifically in your sexual characteristics. You'll have fat deposits, and anyway, we'll look at the picture later. So we have two problems here, possible problems. So we have an overactivity of your adrenal glands or a hypoactivity. The hypo is called Addison's disease, spelled Addison, Addison's disease. And the opposite, if you have too much of the salt, sugar, and sex hormones, that will be called Cushing's. Cushing, Cushing's. There's two forms of Cushing's. There's Cushing's disease and there's also Cushing's syndrome. We will distinguish between the two shortly. Yes. Sorry guys, we're having technical difficulties here in the room. It's not sharing. You guys can see from your end, right?
Yeah, we can
Yes. Yes.
Okay.
Yes,
What
we
about
can see.
Nicole? Can you try joining team so you can see? Okay. Because I don't know how to fix this. Open Teams and then go to calendar, and it should be on your. Can you do it on your iPad? That way your screen's bigger. Was it showing earlier? It was?
It was. And then you click something off.
Okay, let me try again. Can we continue? You're in Teams, right? All right, just watch from your screen. Sorry about that. All right, let's do the insufficiency first. Yes, some of you may have to mute because it's going to echo. Okay.
Minus muted.
All right, so let's begin with the hypo secretion first, or insufficiency. This is called Addison's disease. So in this case, again, there are only 3 hormones produced in the cortex. We have the salt, sugar, and sex hormones. For management purposes, we will focus only on the salt and sugar hormones. I'm not saying we won't address the sex hormones, however, the sex hormones is not life-threatening, so it's not really a priority. We will address it because, of course, that's important for the females. Can you guys still see my screen? Teams, nurses?
Yes.
Yes. Yes.
All right. Where were we? All right, so I described the purposes of the hormone. So aldosterone maintains blood volume, blood pressure, and because it's aldosterone, it causes sodium retention and water retention as well. So that's how it maintains blood pressure. But remember, whenever you have aldosterone released, it will reabsorb sodium, but then you will lose potassium, correct? So what will happen if your aldosterone is low, as in Addison's disease? What will happen to your sodium level? If you don't have enough aldosterone, what problem will we have?
It'll be low.
Okay, you'll have low sodium levels. So that can lead to cerebral edema, fluid shifts, and all sorts of neural problems. It could trigger seizures because of increased intracranial pressure, because there will be some brain swelling here. However, what will happen to your potassium levels?
It's gonna increase.
It will increase. So in Addison's disease, you will have low sodium, high potassium. What happens to blood pressure? Because you're not able to reabsorb water. You're losing it along with sodium.
Blood pressure gonna be low.
Okay, so these are our top problems. So we'll have hypotension, then we have hyperkalemia, and then meanwhile, the sugar hormone, the cortisol, is also low. So what will happen to your blood sugar level? Right, the patient will also have hypoglycemia. So the three main concerns here is hypoglycemia, hyperkalemia, and hypotension. Let's look at who can get this. So it can occur at any age. The cause is usually a tumor. The patient will develop an adenoma in the adrenal cortex. We'll talk about another one later, which grows on the adrenal medulla. So the cortex part, again, is involved in producing aldosterone and cortisol and your sex hormones in the female. Whereas the medulla part, that's where your epinephrine, norepinephrine comes from. So this will not affect the medulla because this tumor is growing from the cortex. So here are your hormones. Please review this on your own. So you have your sugar hormone causing high blood sugar. By this means, it'll convert protein to glucose, fat into glucose, and glycogen into glucose from the liver. And then your salt hormone, obviously, commands your kidneys to reabsorb sodium and water. And here is the medulla. I mentioned already epinephrine and norepinephrine. So manifestations will be related to those problems that we mentioned earlier. So it will relate to the consequences resulting from low blood pressure, from high potassium level, and low blood sugar. So you still remember the signs and symptoms of hypoglycemia?
Yes.
Okay, what about signs and symptoms of hyperkalemia?
Dyslipidemia.
Yes.
All right, what about hypotension?
Yes.
All right, so again, all the symptoms result from those three major problems. We'll have a list of those, too many to list here. You do have some here. Now, when you have Addison's disease, it also affects the level of your acetyl ACTH. So therefore, that will be increased along with your MSH. They seem to be going together. MSH and ACTH both rise in Addison's disease. That's why these people will have a darkened bronze hyperpigmentation. They may also have vitiligo because this will not be uniform. So there will be areas with really dark pigmentation and then areas with none. So it's possible that these patients may develop vitiligo. But most of them will have a bronze pigmentation, a darker bronze tint to it. As far as changes due to lack of sex hormones, so you'll have decreased pubic and axillary hair, which may not always be bad. However, there will be some changes in your reproductive cycle. This is the typical appearance of a Addison's disease patient. Along again with all the signs and symptoms of hypoglycemia, hyperkalemia, and hypotension. I have no questions on the diagnostic testing because really the doctor orders the tests and we are not involved in interpreting it. So we can, however, you are required to look at blood tests, to see if the patient's treatment is working or if they need additional treatment. You already know glucose, potassium, and sodium levels from previous courses. Now, I don't think we've ever tested you on cortisol, correct? Now, because there's morning and afternoon here, so you can clearly see that our cortisol levels drop as the evening comes, meaning we're preparing to go to sleep, so therefore the levels go down. They're higher in the morning, they rise midday. That way, it sustains you every day. Your blood pressure, your sugar levels are maintained. So that's the natural course of the release of these hormones. Now, you can also therefore say that when we're replacing these hormones, because it'll be the same thing with, if you remember what happened in hypothyroidism, how did we treat hypothyroidism? We gave hormone replacement, right? So we gave levothyroxine to replace the hormone because they can't produce it. Same thing here. So you're going to replace these steroids. You're going to be giving the patient hydrocortisone or prednisone. But usually we prefer hydrocortisone or fludrocortisone. They have the dual effect, so they'll have sugar as well as mineralocorticoid action.
So I know someone who has Parkinson's, right? Does this usually come along with like mental health issues, or is that completely different?
Not really. So I don't think the two are related.
Okay.
Did you notice the mental issue before or after they had the Addisons?
Well, I noticed the hyperpigmented and bronzy skin and then I noticed like the mental health, like.
Yeah, they're not really. I don't remember reading it under psychosocial changes. I don't recall. Maybe, maybe as far as the hormones, female hormones go, could be. But is it serious? Like really wacko or?
No, she has a job and something that just like socially, like
inappropriate
or like under stressful situation.
It could be, yeah, it could be because they have they have difficulty when to respond during stressful situations. Maybe it's a learned response, like a defense mechanism. Could be an unconscious defense mechanism. So as you can see here, we have opposites. So low in Addison's, high in Cushing. So it's very simple. Very easy, just like hyper and hypothyroidism. Just don't mix them up. Like I said, we're not doing the testing, so you can skip table 42.3. So only table 42.2. Complications. You remember what was the complication in hypothyroidism? What did we call that when they have severely low thyroid hormones? No, that's the cause. What was the complication? The life-threatening myxedema, right? So the life-threatening complication of hypothyroidism was called myxedema. The official name was myxedema coma. Here, they also have one. In Addison's disease, the acute complication is called adrenal crisis. There are many terms to refer to it. It's called acute adrenal insufficiency, adrenal crisis. Either way you call it, this will be an exaggeration of the three problems. So you're looking at severe hypovolemia leading to shock. We also have severe hypoglycemia and then severe hyperkalemia. All three are fatal. You can't really prioritize one over the other. Each one is capable of killing this patient. So if you have all three, you're hypotensive, you're hypoglycemic, and you have hyperkalemia, I think these patients are still awake. Are they conscious? No. Usual triggers of this are stress. Stress in the form of trauma, surgery, and infections. These are all stressful situations. So whenever these patients undergo surgery, for instance, or any testing, they are at risk for this complication. And again, any one of the three are all life-threatening. Each one can kill the patient independently of the others. So they will all have to be managed at the same time. And therefore, if you have Addison's disease patients being admitted, you always watch them for these signs and try to prevent it. So our goal here is really to prevent. especially if they undergo surgery. Here are again our summary of signs and symptoms. There is emotional lability. If this is going to fit the description that you have with your patient. I mean, because you said mental, it's more like emotional lability. I mean, they go from one extreme to the next. They go really depressed and then very manic, and then vice versa. Very unpredictable. So you check for the 3 problems INO because we need to know fluid status because they do have hypovolemia, which is going to cause the hypotension. So you check vital signs, you check your serum electrolytes, so glucose, potassium, and sodium, and then H&H because that will indicate whether or not your patient is dehydrated or is in fluid deficit. Then cortisol levels. Our level again, what was the morning is 5 to 25, then 3 to 16. Okay. All right, so let's manage each one at a time. So with hypotension, how do we address that? Okay, first is IV fluids. Do they respond with fluids very well? I mean, this is a deficiency of aldosterone. So what would be a more permanent fix here besides IV fluids? We're gonna have to give hydrocortisone. So hydrocortisone will be given here. We can give a bolus of it plus a continuous infusion also of hydrocortisone. And then if needed, we will also give shots for longer term because IV will go directly, so we can give IM injections of hydrocortisone as well. So that's for the hypotension. Next, let's address the hypoglycemia. So what are our interventions for hypoglycemia? Remember, these patients are unconscious, so food is out of the question. Okay, we can do glucagon, IM or sub-Q, right? Or give them 50% dextrose, okay, IV. Or an option is you can hit 2 birds with 1 stone here because for hypotension, we're giving normal saline, right? Some doctors may order D5 normal. That way you hit both volume expansion plus dextrose. Yeah, these patients cannot maintain their blood sugar, so you will give this on top of the hydrocortisone. So you give hydrocortisone, bolus plus a continuous infusion, and then IV fluids with dextrose. Or just give, if the hypoglycemia is really severe, then give separately the glucagon, 50% dextrose. And then finally, for hyperkalemia, what were our interventions again? We have several. What are the ways we can lower potassium levels? The fastest way is IV regular insulin with dextrose. Okay, don't forget the dextrose. Okay, they have to be together. You can't say regular IV insulin only. Regular insulin IV with dextrose.
Can you give
Calcium gluconate. What else?
KX-late?
KX-late, or yeah, KX-late though won't be written on the test because the generic name is SPS. It's sodium polystyrene sulfonate. So don't forget that. Okay, potassium wasting diuretics as well. So either thiazide or loop diuretics. Those are your management. So these are all life. This is called a crisis. So once a patient has one episode of that, we will have to monitor them frequently, meaning do extensive testing on what to do, especially with the next part is in the teaching. Now, these are steroids, so they have to be taken with meals or after a meal. If they take 2 doses, you know that the hormones are supposed to have lower levels at night, right? So therefore, can you give the second dose at bedtime? It should be around early evening. That way we have a time, a chance to lower the level before bedtime, at least, because otherwise they won't be able to sleep. Take it regularly. They should not miss a dose. Now, eventually, these patients will get sick and will be unable to take their hormone. So what should they be advised to do? Because remember, these are long-term steroids, right? And what did you learn in pharmacology? Why can we stop steroids all of a sudden? So Donna, how should we stop steroids?
The medication.
Just like that? Okay, stop it right now.
Taper off. Don't you taper off?
Okay, very good. Right, gradual tapering off, right? So let's say there's a scenario where they're really sick, like they can't eat, they can't drink, they're vomiting, they don't feel well, they got COVID, all right? So now they can't take their hormones. Can we do that? No. Stopping the hormone replacement actually leads to adrenal crisis. In fact, that's one of the most common triggers. So people who have Addison's, and the treatment, of course, is lifelong hormone replacement, right? And then they get sick, they stop, they will go into a crisis, guaranteed, because you suddenly stop the supply of the hormones. So it will trigger adrenal crisis or acute adrenal insufficiency, resulting in severe hypotension, severe hypoglycemia, severe hyperkalemia.
So, Professor, in that case, like if a patient does get sick to that
Mm-hmm.
point, they know that they're getting sick to that point,
Yeah.
they know they're going to be unable to take their medication.
All right.
Could
Okay.
they
Yeah, I
have
forgot to address that. So what should they do if they're unable to take their hormones?
They admit themselves to the hospital.
All right. That's a call your doctor thing. So they'll call their doctor so that they can be admitted. So we can give the hormones IV or at least IM. We can give hydrocortisone IM. But definitely don't stop. They must realize this. They must be taught that the danger of adrenal crisis, okay, the potential for that if they stop taking these steroids, very dangerous. So if a patient with this undergoes surgery and have to be NPO, can we hold these medications therefore? No, these are exceptions. If the patient must be NPO, they must be given an alternate form of the drug. So this is your job. You're preparing a patient, you know they have Addison's, they're taking hormone replacements, they must, under no circumstance, they must not stop it. And then the doctor's aware of that. We cannot stop this abruptly. It has to be tapered. However, just like hypothyroidism, is there a possibility that they may take too much of the hormone? Yes, because our hormone needs do not stay the same. They change. We require more when they're under stress. So that also requires dose adjustment. That's also another call their doctor thing. And the doctor will check their levels, and if we need to raise the doses, we will. Because there are changes that we undergo. Let's say you're getting married, Justin, or you're giving birth, Medusa, right? So our hormone needs change. So the doses must change with these developments, right? So coordinate with the physician. And there's a chance that you may take too much of it. And then now you'll develop the other problem. So you'll go from Addison's to now Cushing's syndrome. So Cushing's disease, which is now the next topic, is a primary problem of the adrenal gland or the pituitary gland. Cushing's syndrome arises from exogenous steroid ingestion, meaning you're taking steroids for another problem. Addison's disease isn't the only people taking steroids. We have lupus patients, rheumatoid arthritis patients, Crohn's disease, ulcerative colitis, psoriasis, organ replacement patients, asthma, COPD. So we have countless people, almost all patients with autoimmune diseases take steroids, long-term steroids. So therefore, all of these patients will be taking steroids every single day. So there's always a chance that they'll develop Cushing syndrome right here. So Cushing syndrome is because of exogenous corticosteroid medication administration, meaning they're taking a steroid. No, the steroid doesn't come from their body, meaning they're taking it as a supplement, okay, as a replacement for another condition. So if the Cushing's develops because of that, it's called Cushing syndrome. Because we can treat it by adjusting the medication, meaning they'll have symptoms, but it's because we gave them too much. So the doctor therefore can adjust the dose and it can be resolved. Cushing's disease, on the other hand, is a different story, because in Cushing's disease, this is now either an anterior pituitary problem, usually a tumor again. So that the pituitary gland has an adenoma causing too much ACTH production, causing overstimulation of the adrenal cortex, resulting in Cushing's disease. So if it's that, meaning it's your own body causing it, it's called Cushing's disease. If it's due to taking hormones, meaning the hormones didn't come from your body, we call it Cushing syndrome. Is that clear? Any question between disease and syndrome? You understand? Okay. It's important to distinguish again because the treatment will be different. Before we go to cons, you know what? Con syndrome is jumbled into here, so let's do that. In con syndrome, this is not the same as Cushing's disease, because this is now only affecting aldosterone. The cortisol is not affected here, neither are the sex hormones. So this is a tumor again, growing in the adrenal gland, but this tumor only causes a hypersecretion of aldosterone. So you have high levels of aldosterone, so therefore what will happen to your sodium levels? You have high aldosterone. Yes, Israel?
It will increase.
All right, so you have these patients will have severe hyperenergemia. So will they be very thirsty? Yeah. Will they have severe water retention?
Yes.
Yeah, you betcha. You'll have edema. And what happens to blood pressure here?
It will go up.
All right, so our problems here, and then the potassium will
Go down.
go down. So symptoms again will be related to hyperenergemia, hypertension, hypokalemia, and fluid overload. Right? We can't name them all, but you know, this is your last semester. You're supposed to know signs and symptoms of hyperenergemia, hypokalemia, hypertension, and what was the last thing I said? Hypervolemia, a fluid overload. So you'll have lung crackles, etc. It's not very common. I've only seen one patient with con syndrome. He was just admitted, he was just diagnosed, and you can literally open the textbook and look at the guy, and he has all of them. Okay? He was classic textbook con syndrome. He was 35 years old, miserable. Number one complaint was headache. His blood pressure was always 180, 200, and he's only 35. This is now Cushing's. So you still have emotional lability, just like in Addison's disease. You have the moon phase. These are all related to excess sugar, excess cortisol, excess aldosterone. So you have fluid retention because you have hyperglycemia constantly. What does the body do to excess sugar? It will turn it into fat. So you'll have several fat deposits here beyond your liver. It will now go into your abdomen, causing abdominal obesity, and yeah, the same. Yeah, Cushing's disease syndrome, they resemble the same. The only difference is the cause. How did it develop? But they all look alike, right? They same exact signs and symptoms. So because you have more fat, there will be less muscle mass here. There will actually be skeletal muscle atrophy, because now you'll have more fat deposits. The problem here is because this is meaning they have high stress hormones, correct? So when you're under stress, what happens to your gastric acid secretion? It increases. Now, can you absorb calcium with a really high acid? No. So the patient will have hypoglycemia here as a result. And then we have hypokalemia as well, because now we have hyperenergemia, correct? Hypokalemia and then hypocalcemia, because they go together. Potassium, calcium always go together. Then you have the high blood pressure, and then the deposit of the fat here is so fast, meaning they develop over a short time. So there's no time for the skin to adjust. There will be stretching here. You'll have stretch marks. The skin will also thin, meaning they're very prone to injury, both skin tears plus if these guys fall, which they do because they have weak muscles, because they have more fat. They are prone to falls and they can easily break their bones because of the hypocalcemia. So they have central obesity. So you'll have most of the deposits here and also at the back here, buffalo hump and the moon face. They'll have purpura, easy bleeding, because there's also a bone marrow problem here, resulting in, plus you have your immune system is suppressed because you have very high levels of stress hormones. These are corticosteroids, so they will suppress immunity. So they're prone to infections, poor wound healing, and the treatment really is surgery. We'll have to remove that tumor. There is medical treatment, drug treatment, but it's only temporary, so it's not worth testing because the patient will be on it for a short while only. So our major treatment really will involve surgery. So we'll skip the medical part. We'll go straight to surgery. We won't do the testing because the testing involves dexamethasone suppression tests, but that's complicated. Again, the doctor does all that anyway. We're not really involved. However, we will look at the labs. Okay, we already looked at the labs earlier under Addison's, so we'll do the same. So what happens to sodium level again? High. What? Your potassium? Low. Cortisol? High. So these drugs here, we'll skip it because again, they're only for temporary. Temporary as in a few weeks. Surgery is your permanent. No. This is different because in Addison's, we replace the hormone, right? So these ones will, no, they're not, they don't work like that. They don't drop the hormone levels. That's why, again, they're not effective. So they only have temporary relief. So what we'll do is really surgery. So now this is equivalent to hyperthyroidism, correct? Because this is now hyper secretion. You remember how we prepared the thyroid patient? We give. Remember, because we gave 3 drugs. We gave 2 thionamides, which are methimazole and polythiouracil, PTU, and then there was Lugol solution, right? The iodine preparation. Okay, so we'll do similar here. Because imagine, Cushing's disease patients, are they used to really high sugar and salt hormones? Cushing's, yes. Every day they have high levels of these. So what will happen? If you take them to surgery, clamp their arteries supplying the adrenal gland, and then cut it out, what's going to happen to the hormone levels that they're so used to having high levels of? It's going to drop. Is it going to drop slowly or going to drop drastically? Drastically. Is that equivalent to stopping the hormone replacement immediately?
Yes.
It's the same exact thing. What can they develop is that if you suddenly stop the hormones, adrenal crisis. Can they die during surgery, therefore?
Yes.
Yes, you'll kill them. They'll go into adrenal crisis and die on the operating table. So just like in hyperthyroidism, we will kind of feed them. Remember in hyperthyroidism, they were in a negative nitrogen balance. So we gave them a high protein, high calorie diet. And then we gave them iron preparations, right? So we'll do the same for these patients. They're immunosuppressed. They will heal poorly here because their levels are so high, you know, steroid levels are so high, so immune system is suppressed. So we'll give them um, high protein, high calorie diet to, you know, to prepare them for surgery so that they will heal after surgery. But you do realize after surgery, they now, if we take out both adrenal glands, meaning no adrenal glands left, or same as thyroidectomy, after total thyroidectomy, what do they have now?
Hypo.
Addison's.
No, with hyperthyroidism, if you take out the thyroid, what do they have now?
Hypothyroidism.
Hypothyroidism. So this one, they started with Cushing's, and then we removed the adrenal glands, both of them. What do they have now? Addison's disease. All right, so you prepare them now for that. You explain all this. Okay, this is the plan. This is what's going to happen. So if you remove both, of course, they will have Addison's disease. However, if you only remove one, meaning the adenoma only affects one adrenal gland, then they'll probably be taking the hormones maybe 2 years. And then until the remaining gland will compensate. It will compensate for the loss of the other one, and then they'll stop the hormone replacement. But let's go with the preparation. So we will make sure we give them the high protein, high calorie diet, and then we will have to give steroids here because when we resect it, when we remove it, no more steroid. So therefore, they will be receiving a steroid infusion before, during, and for life after. Of course, it won't be infusion, but you know what I mean. Just during surgery, we'll give them infusion, steroid continuous before, during, and then shortly after, and then after that, it'll be oral replacement because they now have Addison's disease. They'll be taking the hormones for life. But since now they're in Addison's, can they develop Cushing syndrome someday? Yes. So it's important to educate the patients here. So now you have Cushing's disease. After this, you may go to Cushing syndrome. All right, but they have no choice. I mean, how else do you propose to treat this? All right, but at least with Cushing syndrome, can you manage it? Yes, the doctor can adjust the doses. That way, you know, because they might feel like, oh, this is deja vu all over again. You know, I started with this, now I look like this again. So at least with syndrome, you can manage it. The body appearance, the body changes can be managed, okay, with proper dose management. As far as hyperaldosteronism, same thing. You manage their symptoms. They manage the severe hyperenergemia, hypokalemia, and the blood pressure. So these guys will be on a lot of blood pressure medication. So beta blockers, ACE inhibitors, diuretics, calcium channel blockers in order to keep the blood pressure low until they can get surgery. The only permanent treatment for hyperaldosteronism is surgery. You have to remove the adrenal gland. And then now what do they have? Addison's also. Unless we only removed one. Before surgery though, your number one priority is really to prevent the complications of the severe hypertension here, because they could have a heart attack, a stroke, or even kidney injury, right? So they'll have organ damage here.
So I
So
was gonna ask you, like, are you, because for the adrenal gland test, you're gonna be monitoring your health.
yeah, because you watch for fluid retention. So a slew of antihypertensive medications here, vasodilators, beta blockers, ACE inhibitors, diuretics, potassium sparing diuretics, because they're already low in potassium. So we'll use potassium sparing. We also have a complication in Cushing's disease or Cushing syndrome. If we had acute adrenal crisis, we have something here in Cushing's. I just forgot the name. What's it called? I forgot. It's not Cushing's crisis. It's huh? Anyway, I can't remember. So management besides surgery, remember these patients, besides surgery, before surgery, I mean. So what are your nursing care? They are prone to fracture. So therefore, how do you manage that? Somebody is prone to fractures. They have hypoglycemia. Yeah, but besides nursing care, how do you manage? Okay, and fall precautions, right? And then you remember they're prone to skin tears, so handle them safely. Do we give liberal fluids? Cushing's disease or syndrome? We give them a lot of fluids?
No.
All right, you already have edema, right? You already have hypertension, so restrict it. What about sodium intake? Okay, restrict sodium. Now let's go to the hyperacidity, which contributes to your osteoporosis from hypocalcemia. So how do we address the high gastric acid content?
H2.
What did we do? We just finished gastric peptic ulcer. PPIs, okay, or H2 receptor blockers, or ranitidine, famotidine, or your lansoprazole, omeprazole, mesoprostol.
So I have a question.
Yeah.
Don't PPIs waste bone? Like, don't they cause some sort of osteoporosis?
In long term, yes. But remember, we're only using it until they can get surgery.
Professor, but
Yeah.
In PUD, why do they use sulfur in the first priority before mesoprostol?
Say again?
In PUD, they use sulfurate.
Sucralfate, okay.
Yeah, but they say it's prioritized before misoprostol.
Misoprostol?
Yes.
Well, misoprostol is only given if the patient is taking NSAIDs.
Oh, okay.
Meaning it's your protection from the NSAID. That way you don't get PUD. Meaning if a patient must take NSAIDs for some other condition, then you give misoprostol with it to prevent peptic ulcer disease. So here's your GI prophylaxis. You give them PPIs or H2 receptor blockers, whichever the doctor gives. I already mentioned the consequences of Con syndrome, hyperaldosteronism. So we have organ damage, kidney failure, stroke, heart attack, and dysrhythmias because of the hypokalemia. Here's a summary of our Cushing's disease or Cushing syndrome. Again, the males will have the same except for the sexual characteristic changes. And I already mentioned this, the headache, the hyperenergemia, hypokalemia, and hypertension. All right, so for the wound healing, we already mentioned, right, that we're gonna give them high protein because the wound healing will be a concern here. Because remember, we started giving them steroids, which suppresses immune response before, during, and then forever after surgery. All right, that's it. Let me just make sure we covered everything. My iTunes is not opening. Can somebody open your exam 1 blueprint, please, and run down if we missed any topic?
We covered post-op and ulcer disease, GI